So we've cleaned the skin with alcohol. We're now going to go local anesthesia along the incision. This is cause local as well as hemostasis during the dissection. Okay, so that's the incision. We're going to be dissecting in the plane between the inferior border of the mandible and the mandible itself. So you want to make sure this doesn't hurt. Good. So that's the initial from the incision, soft tissue dissection. Now what we're going to do is we're going to hydrodissect right in the bone. So this is right now on the periosteum, doing the dissection. Slow resting now, you're doing great. Okay, so we're going to be going down the mandible, doing hydrodissecting right in the periosteum. Okay, good. So we continue that at the lateral edges. This does two things. One, it decreases pain, along with the epinephrine causing less bleeding, but you're hydrodissecting in the plane right on the periosteum. So you want to make sure that there is no discomfort during the surgical procedure and no bleeding. So you can see, again, this is right on the periosteum of the bone. And then we do the other side. So that's the local procedure for hemostasis and hydrodissection. So this is a extended anatomical chin implant. We'll probably be picking a medium anatomical chin implant. The medium anatomical implant will be at the base or the inferior border of the mandible, and it'll be positioned at the inferior border like this. So that's about where the implant will go. When we're done, templates are blue, the implant themselves are clear. So incision is very, very small. 1.5 centimeters is all you need. You go along skin tension lines. The smaller for most patients, the better. You can actually do a lot of stretching of the skin by retraction. So we're going to do first, we're going to put a retractor in and retracting up. So the section on this point is the care is to not cause any injury to the skin. Lower the bovie to 16. Okay, so the dissection is now going to then extend superiorly up. There's nothing you can hurt in this plane. We're in the midline. There's no specific nerves unless you go more laterally. So the dissection is going to be kind of superiorly up towards the inferior border of the mandible. Okay, so we're basically at the inferior border of the mandible at this point. Change to a longer retractor. The dissection now at this point will be going down towards the bone. Try to keep it as dry as possible so we can see. Okay, so we're now with the dissection at the inferior border of the mandible. We're now going to dissect on the bone itself in the lateral position on both sides. Once the implant's in, you want to make sure that it's in the midline. So here is the midline here's the midline of the implant. So that's in the midline. The next thing you want to make sure is that the implant is at the inferior border, and we're going to immobilize it there so I can feel it's at the inferior border. The next thing you want to do in this maneuver, make sure that it's not folded. With a regular implant, it's rare that this occurs, but a conform implant, it can fold upon itself. So you take the periosteal elevator underneath the implant, you go along the inferior border underneath the implant on one side, And then you do it on the other side. Again, this is enabling that it does not have it folded. So I go through the other side, and there we go. So either side is not folded on itself. What can happen with an implant, especially the conform implant, when you place it, it can go and fold like that. So if you go through your periosseal elevator and go like this, it'll make it so it's flat. Okay. So implants are made for unisex, okay? And obviously women are feminine, men want to be more masculine. So classically what we need to do is usually between about 1.5 centimeters off of the midline of the implant in women. And this is where we're marking that. And we measure this on the patient to be correct. And it usually lasts about 8 to 10 millimeters, which is right in front of here. And here, 8 millimeters. So this is the area that we're going to trim to make it so it's less of an issue with masculine looking implant. So to do this, it's very hard to do this with a scissor. So what you do is you do it with a knife blade. So what we're going to be doing is we're going to be carving the implant with the needle in a horizontal fashion, okay? So what that does is it makes it so it thins out the implant. So it's easier to do this with a larger blade. So we're going to be thinning this implant in a paramedian aspect. So you can see right here is we're thinning this so you don't have as much fullness in the paramedian area, which can produce a squared look in a woman, and they don't like that boxy squared look because it looks more masculine. So doing this with a sharp 10 blade is the way the technique should be done. So that is narrowing the paramedian position. Silastic implants are made so you can carve them, okay? A lot of surgeons feel like they're fearful of doing this. If the patient gets a good result, except for they feel it's full there, there's nothing you can do except take it out and put a new one in. If they have more deficiency, you can always add fillers, either something that's temporary like a hyaluronic acid filler, or you can add Bellafill, which is a long-term filler in that area, to improve the appearance of the pre-gel sulcus by filling that in slightly. I trained at Stanford. Harry Middleman invented the pre-gel implant, which is basically nothing anteriorly at the anterior chin, but fills in the pre-gel area with an implant. I classically just use a Bellafill or a filler for that, Bellafill being permanent, or you can do it with fat transfer, okay? So again, this is a tapered appearance to the sides. This side, I think I need to take a little bit more off. If you need to, you can switch over to a sharper blade. Okay, that's more symmetric with the other side. And you do it in a feathered appearance, so it's not a ledge you can feel, okay? So even though that doesn't look like much, that feathering can make a big appearance to a patient that is a female and wants more of a aesthetically pleasing, less masculine look. So I think that helped on both sides. We're going to take a tiny little bit more on this side, and then we'll be finished. I classically irrigate the pocket out with betadine. You can use betadine with antibiotics in the saline solution. You want to do the entire case as sterilely as possible. I've never had a chin implant get infected in my career. The biggest issue I worry about is that I put it too low. So that's one thing we're going to be concerned about. Okay, so this implant now is carved in the paramedian position to give it less of a boxy look. Now we place it. So we have the bone exposed from electrocautery. Now what we're going to be doing with the periosteal elevator is a smaller Fraser. We're going to be dissecting minimally superiorly because we don't need to go too far up here. We're not going to be exposed anywhere close to the infraorbital, the mental nerve, pardon me. We're dissecting right at the inferior border of the mandible, so we're going very, very slowly. You want to find the concretions of periosteum at the perimedian area. So that's right here is where it's stuck. So this is really the entire key to the surgery. You want to stay on the periosteum, and you're going more laterally. This is the alpha for retraction. You're right on the bone, okay? So you're staying right on the bone for the dissection. So this is in the perimedian area. You're feeling with your fingers, elevating that periosteum right off of the bone. That is really the key to the entire surgery. So this perimedian area is slowly elevating that up. You want to make sure you stay on the bone for the entire process. If you're not sure and you come off, which I just did, I'm going to go back with my retractor and make sure I'm right on the bone. So that is the concretions right in this area that you need to lift, or the implant will not stay, including the lateral arms, on the bone laterally. So we have a medium-sized implant, and if you could see the size or width of the periosteal elevator, this is the appropriate size. You want to use the smallest one possible for your dissection. So we usually start out with the Fraser tip to get it elevated to get the flap of tissue. You can see this is a Tessier retractor, and you can see how wide it is. So you don't necessarily need to make the pocket that big. So this periosteal elevator I wouldn't use. Actually, Implant Tech has 3 periosteal elevators that you can use that are different sizes. So this is a MOLT, or a maxillofacial surgery piece of equipment. That's a periosteal elevator. That's the size that we can use. So what we're going to be doing is we're going to go right on. We've already now dissected. The key is this confluence of periosteum that we've elevated. So we elevated superiorly here, and then when you go superiorly, you can see the height of this implant is probably about 10 to 12 millimeters. So going up in the superior position, you don't need to go that high. You don't have to go up to the supramental crease. But the key is, again, once you get past this confluence, then you're going to stay right on. It's easier to feel with your hands. You want to go slightly past the extent of your implant, which we drew on her mandible. So you go slightly past that, because when we put the implant in, what we need to do is we push it into the pocket, and then we need to push it a little bit farther, so then we can put it on the other side. So that's why the dissection laterally goes a little bit farther than the measured amount. Classically, I guessed her a medium, so we're going to put a medium implant in, see how good that is. We may go one smaller, small. We may go one larger, medium. Pardon me, large. Medium is probably the one we're going to have. You never want to put too large a facial implant in contrast to breast implants. If you can make an error, you'd rather go too large, too small. Facial implants, you'd rather go too small than too large.